one of the things that I would say when we look at the impact on the surgical wait time, so one of the things that I think we are trying to come up with as, how, when you really think about a growing wait list, like, is this really going to have an impact, if we're taking away, 7 patients a week, or, quite frankly, even 14 patients a month. So how could we get moving a little bit faster through that? And one of the proposed model is not really getting people into doing a full biomechanical exam and a neurological exam, for example, with spine patients, where, as Dr. Senek alluded to earlier, a lot of what we could do could be done and captured with specific assessment tools ahead of time. So as part of the triage, the patient's going to come in, and much of our subjective could help to identify that this is not a surgical case. And we would be able to do that, and where actually our proposal would be is in a virtual world, we could actually probably cut down on a lot of our sort of in-between time. So we actually think we could increase the number of patients we'd be able to see in a triage, with the anticipation that the PT at the end of that consultation would help the patient and really take over from there. So it would limit the amount of time that the surgeon would have to do at the end of a consultation. So Alex, if I maybe throw it to you to maybe put your kind of thoughts about how we talked about that over the last little while, like what your thoughts on feasibility would be, and then we'll maybe throw it to the group for concerns around risk.
Yeah, so I think, so me and Daryl have been working together for about 7-8 years. And we in person, we've done a model where we'd see a bunch of patients, and while Daryl is examining the patient, doing the quick history and all that stuff, I'd be looking at the MRI scan, and then I'd pop in. And with that type of approach, we've, like Daryl said, many of these people would be very happy that with his recommendation, and then a bit more people would like to hear from the surgeon as well, right? So we did this in person, and we'd ideally like to do this in a virtual manner as well. And that's why this whole discussion has come about, where Daryl would basically see the patient virtually, and then I'd pop in the last few minutes as well as through the virtual camera. And at that point, I could be reviewing the MRI scan, or I could even be doing even paperwork or even research work, or flipping through my 250 referrals I get on a monthly basis type thing, right? And just it'd be all one of the issues that we talked about would be the timing issue, right? So Daryl say it takes like 20 minutes to see the patient and to get a history and all that stuff, and then Daryl's going to say, okay, be available for 9:20, Alex. And so you could basically give your recommendations to the patient, whether they're surgical or not, or whether they go forward with some conservative therapies, or we send them for a nerve block, or we send them for an EMG study. So that's one of the issues or things that me and Daryl have discussed, and felt that some people might look at that as somewhat of a disadvantage, or create some difficulty, because you have to logistically get your timing right, and so the poor patient doesn't have to sit there waiting to for me to chime in. So I think it wouldn't work if you're in surgery. It wouldn't work if you're doing a clinic with an inpatient clinic, and but in situations where most of us are involved in academic research, or just even doing paperwork that we're all accustomed to, I think we could definitely work in a smooth manner.
If I could make a comment, we've been using that model with the Ontario Workers Network for the past couple of months, and it works very well. Often the therapists are in their own space, and I'm in a different place, and the patient is in their place, and it works very well. And like you said, Alex, the physio is doing a lot of work and discussion with the patient, but I come in and have further discussion and talk surgery not. But where I find it very helpful is that oftentimes, just with, as you were saying, patients are referred, but they don't have complete workup. Do you know what I mean? So it's often really a nice meeting that you can get at real soon and say, look, here's what we're going to do. Here's what we're going to discuss. I can tell you right now, you can carry on with some physiotherapy, but you know what? I'd like to get an MRI, and we're going to have a look at that. And then after you do that, I'd like to see you in person. And then you can follow up in virtual as well. So I personally think it's very successful. I personally feel that you can get at some of the workup work that you want to do, that you're not going to make that final surgical decision on. You can still see someone in person, and yet you can set them up for virtual follow-ups. So personally, I think it's good. And like you said, I found personally that I'm not going to operate on someone until I can touch them, but I can think about who's a good surgical candidate and then move that way. Yeah. So I found it very useful. I don't think it's going to replace everything, at least in our practice, but it's definitely a way to triage things and get things on the go, I've found.
But wouldn't you agree? Brad, and others here, that I mean, intuitively, it just makes more sense for us to be no longer siloed as we are in general. Like, for example, evidence-based practice is always outcome-based and individual, right? So we have an outcome we're trying to prevent, but we're all trying to prevent an outcome that's relevant to our specific silo. Yeah. But we had a session today from Amsterdam in one of our virtual sessions. I think a few of you may have actually been at that one as well. But it's value, and the value chain is not about a single event. It's about the group. It's the patient's path from the time they have their first contact with healthcare to the final result, all the way through, right? And we can almost argue that you can go bigger and bolder. You could actually have much more people, many more stakeholders in that patient's value chain, and then say, okay, how do we, in this whole episode of care for this patient's care, provide optimal treatments? And you can also make the argument now that if you look at major advances in orthopedics, whether it's hip fractures or total joint replacement, you're not likely going to see some device that's going to somehow revolutionize care, because every large trial that our group has done has shown is getting more towards no differences between treatment A, treatment B, surgery. Rarely do we have some big win on a treatment. The real advantage is going to be likely preoperatively and postoperatively, whether it's medical timing, whether it's rehab, whether it's all those other things. So it does make a lot more sense to be much more engaged at an earlier point. And this type of discussion should be happening a lot more than it is.
Oh, absolutely.
I'm just wondering if there's anyone else who's gotten a thought or opinion around this issue specifically. Yad, I see you coming in, and obviously we'll get Damian in as well. So Yad, you want to go first? Okay, we've just lost Yad. So Damian, you're up, my friend. And I think you're just muted.
Hi guys, I'm Damian Griffin from the UK. I'm pleased to tell you that it's 2:30 in the morning, so I think this is a really important subject.
Well,
I was for joining.
It was hilarious. I said, this is Professor Griffin's waiting. I said, this is truly in the UK. This is an early morning, but thank you for coming.
So I'm a hip preservation surgeon, and I lead a team that's 3 surgeons, 3 physiotherapists, a radiologist, and of course residents and fellows. And we have for some time had a multidisciplinary team meeting once every week, where we look at our most complex patients and we think about how to manage them. But just in the last 6 weeks or so, since COVID stopped us doing any of our routine work, we've tried to do what Mo is suggesting, I think, to use COVID as a launch pad for doing something better than normal. And I'll outline what we're doing, and I'm really interested in your reactions. So we have arranged for all of our new patients to come and see one of our physical therapists in a virtual appointment on a video like this. And that physiotherapist goes through the patient's history. They do what they can of an examination by asking the patient to do some movements on the screen. And the physiotherapist looks at the imaging that the patient has along with the patient. And they go through all of that, and it might take them 40 minutes to do a complete assessment in that way. And then on another day, that physiotherapist and the rest of the team all meet up for a multidisciplinary team meeting. And that physiotherapist will present that patient to the rest of us. And generally we're in different places when we're doing that. So it's a virtual meeting just like this one. Of course, we can look at the imaging on the screen, and the radiologist will talk us through that. We can listen to the physiotherapist presenting the history. And we can all talk about how we think we might manage that patient. But also we can talk about what critical information we don't yet have, what things we'd like to ask the patient or see that patient do or show us. And then we call that patient into the MDT meeting. Now, we've never done this normally. We've never had patients physically in the meetings, but this way we get the patient into the meeting, and one of the surgeons or the physiotherapist, depending on which we think is going to be the lead specialty, will lead the conversation with that patient, but all of the other doctors and physios will be part of it too. And that meeting with the patient takes about 10 minutes usually. And at the end of that, we come to a conclusion that's been agreed with the patient, and then from that, we have a treatment plan. Now, this seems to us to be really efficient because we've got everybody really contributing where they most can, but we also seem to be getting enormous patient satisfaction from it because they feel that a whole team is looking after them. And what we realized was we essentially been doing the same thing before COVID, but the patient didn't really know about it because they never saw the rest of the team. Maybe this is pretty exciting because now the patient sees the whole spectrum of specialists that are looking after them and gets to hear comments from many of those specialists. Now I'm beginning to wonder whether we'd ever want to change this back to the situation we had before COVID.
And I think, yeah, and I would say, Damian, I think the hardest thing is going to be this immediate pull back to old ways. Now, I think we all say that we've changed. Like for some reason, this particular moment in history has changed and has been that one spark that has changed everything. But there is this real pull back to norms, right? The minute clinic space opens up, and we have this tendency to go back. And I can tell you, we did a survey which was almost the opposite of what people are at least signaling when they talk to you, because everyone says, our virtual care has been amazing. We've adapted quickly. We're moving in the right direction. But they're doing it in an environment where there wasn't another option. So, there was this optimism around we're going to make it work. But then you say, hey, by the way, when you think you're back to normal, what's the likelihood that you're going to be using virtual means? Oh, I might use it once a week, maybe once a month. I mean, these are surgeons speaking, so I'm not speaking to all groups, but not everyone's adopted. And I think even within our physiotherapy colleagues and rehab colleagues, there's going to be the adopters and those that are a little bit, skeptical about this approach. I think it's going to require us, as you're suggesting, as teams to come together and really do everything we possibly can to figure out what works and what doesn't. And I think you have a compelling argument. I think the reason we're having this discussion tonight is just because of that specific reason. But anyways, I'm very hopeful that we can find whatever you want to call the cliche term a new normal in this. But there have been some real important advances that have come likely from this approach. I want to make sure though, if we could, Damian, get a few other people engaged. I know Yad, you had a comment, and I know that there's another comment from Rohit. Rohit, did you want to go first, and then we'll get Yad to come in?
Sure. Thank you guys for having this discussion first and foremost. I guess my question as a physiotherapist now is who leads this, patient-centered but multi-team based approach where we're using the virtual care? Is it the physio that does run runs the meeting, or is it the surgeon or the MD? So how does that, assignage happen, and where do we, start on that pathway going forward? And the second question would be, how do patients meet a minimum requirement to have, this type of dialogue set up? Knowing how busy surgeons are and how busy we can be, either whether we're in clinics or virtually, it's going to be a really difficult time to say, you meet the certain criteria, whether you're going for surgical or non-surgical. So do we have a minimum criteria that's based already to say, hey, patient X fits this minimum criteria to do this, virtual team approach, let's go with them? Or this person right now fits a more fits a more conservative approach, you're going straight to the physio, and then if that doesn't work, then we go down the surgical pathway.
So I'd say, if you don't mind me commenting here, so from my perspective, what I find is, so for example, you see someone with a huge honking L4-5 disc herniation versus a small little disc herniation. Someone like that, I'd probably see personally. It's those gray zones that I'd be sending to Daryl. You know what I mean? And that's where, because I know I'm going to be spending a lot of time with this, like, someone with, severe cervicospinal stenosis, right? And the family doctor says he's got numbness, he's dropping things in his hands, or, classic neurogenic claudication, can't stand, can't walk, needs to lean forward and all that stuff. Stenosis, well, that guy I'm going to probably see, because I know I'm going to book this guy for surgery, a high chance of that happening, right? And I'm going to have to spend more time with this individual. It's those gray zone areas that we think, or even the people that, just have classic mechanical low back pain, based on the MRI, they're non-surgical, but, they still want to see somebody. They still want to have someone like myself or Daryl or a combination of us both to assess them and say, hey, you know what, you don't need any surgery, right? So that's what we're doing in favor of society that way.
Okay.
You know what, if I can just get Damian to jump back in. Damian, are you selective in how the patients are being seen, or are you just saying all comers are coming in that model that you have?
All comers, really.
Yeah.
So we have a triage system that makes sure that the patients who are coming into our service are appropriate. And that's just really by scanning referral letters. So if we see someone who's, 75 years old with obvious osteoarthritis, we're going to divert them to an arthroplasty service. So not those, but everybody else comes in. And in our model, everybody gets seen by a physiotherapist first. So we're sort of using our physiotherapists as the people who are going to gather all the information, package up that information for the team. And we're doing that partly because our physiotherapists are very good. They know what they're doing. And partly because many of our patients will need a component of physiotherapy in their management. And for a good number of patients, that will be the main component of their treatment. So we sort of want the physiotherapist to see them first to make that judgment. But then, maybe this is the thing that's different from what we were doing before COVID, is all of those patients are being seen by the whole team. And so even if the advice to a patient is, you should be managed by a physiotherapist and we're going to give you a program of exercise to treat your problem, that patient is reassured that all of their imaging has been looked at by the whole team. They've seen some surgeons on the screen who've been making comments about the advisability or not of surgery. And they feel, yeah, I've been fully assessed by a big group of people who are looking at my problem from different directions. And I'm confident that I've got the right answer at the end of this process.
Extremely helpful.
I personally would agree with that as well, just from our experience. To Rhodes' point, and Damian's, the physio leads it and creates that package. And then I'll pop in, bring them out of the waiting room. We'll all have a discussion. Oh, I think we need some pain, pop out. Someone else from the team pops in, and everybody's in on it. And I agree. But we're similar to what was just mentioned, that the physio takes the lead, makes the package, and we all have a discussion. And you're right. Oftentimes it's the physio then takes it afterwards for therapy, prehab, post-hab, any of that sort of stuff. People like the whole concept, even if they are surgical, of the prehab type of thing, and that sets them all up. So I agree with you completely. I think that model works.
Yeah. Can I ask a quick follow-up?
Yeah, go ahead.
So I noticed that working in private practice and in athletics, I see a disconnect between myself and some of the orthopedic surgeons that I do work with. So do you guys have any ideas on how to create a more engaging atmosphere between myself as a therapist and them as a surgeon, then, such that there is this rapport where we can go back and forth and share these documents or these findings together to have a more comprehensive approach, as opposed to me just writing a letter saying, hey, I saw this on initial consult. What do you think? Is this person a candidate for surgery, or can we get more imaging or something of that nature?
Anyone want to take that? Who's had
Good
success?
question.
Yeah. Oh yeah, go ahead, Damian.
So it sounds, Rohit, as if you are working normally in an independent location from the surgeon. Would that be right?
That would be correct.
So I've got to say, I think that's the problem. So if we ignore post-COVID situation and virtual consultations, just being physically separated and having the patient come and see a physiotherapist in one place and then a week later go and see a surgeon in another place, that's not conducive to collaborative working between the physiotherapist and the surgeon. So I've always tried to get the physiotherapists I'm working with on the same site so we can see the patients together. So you wouldn't be sending a letter, you'd be popping across the corridor to have a chat. But that's tough to do normally because of the difficulty that we are in physically different places. So that's where using virtual consultation gives us a massive opportunity, because now we can get together, and it sounds like Daryl and Brad and myself, we're all using slightly different ways of doing it, but the principle is still the same. We're bringing different specialists together to focus on that patient in a way that we couldn't have done if we depended on doing it physically. So this may be the opportunity for you to solve that problem. Have you and your surgeons working together in a multidisciplinary clinic, even if it's a virtual one.
Okay, thank you.
That's you got to grab that buy-in and establish those relationships, because in our, even with Daryl and Alex, and we all know that we've all established some significant relationships with physiotherapists and surgeons in our setting, and you're right to put people in the same building at the same time pre-COVID. That's very important, because that rapport develops quite quickly, actually.
I mean, but I guess right now, I mean, there's an opportunity to really push the opportunities of virtual care, which still allows you to do something rather than nothing.
Absolutely.
Right. And just a matter of someone figuring out the scheduling around that. But I think if there's ever a time, Rod, it's now. I mean, it's now to be starting to reach out and talk about possibilities, you know, and hopefully you can get in touch or connected. But I think these kind of discussions are where we have to be doing more of than less of. Yeah, did you want to say something? I've been trying for a good 10 minutes to get you on here, so I'm going to give you your shot.
Yeah, thank you. Well, I think a lot of what I was going to say was already said, but I think it's important to note that the virtual allows for that collaboration, and that's what the patient's seeing, right? So it's no longer this game of broken telephone. Like, I told my ortho this, and then I told my physio this. This is a platform to have that conversation with everyone on the same page. But I actually wanted to bring up a second point, and that was, what are the drawbacks to doing virtual assessments? What are we missing on? Are we potentially missing out on speaking to expectations or the nuances of in-person practice that we're missing potentially through virtual?
Yeah, I think it's undeniable that there's going to be, like, you know, for example, you know, we could have had, if we were in a room together, I think it would have been ideal. A webinar for us would have been less ideal, and this is sort of the mix in between, where we get closer to having a meaningful discussion that we probably wouldn't have in the webinar, right? So I know that there's elements of virtual that are very helpful, and there's just elements where they aren't. And I guess that gets back to what Alexa was saying in my mind, which is there's going to be situations where there's going to have to be a touch point, you know, for inpatient or in-person examination. I'll let Brad speak to it, but I would imagine that that's going to be part of the algorithm, and how you set it up is going to be part of that. Anyways, yeah.
Well, I agree, and it's some of the problems that we've encountered are very sort of low level, mundane. You know, because I do a lot of foot and ankle recon, and it's kind of like, you know, no, put your camera down, angle your camera, you're on your phone, like, it's that kind of stuff. Do you know what I mean? I can't see your foot. Who's holding the camera? You know, that kind of stuff. And that will come, I think, with time and with things. So from our point of view, you know, today, just even, you know, I have patients that I can't see because they're just technical issues. They just glitched out. Do you know what I mean? So, and I think those will change with time. It's not the patient perception as a problem. I think it's just, for us right now, it's just some technical issues. And then when that happens, then nothing you can do.
Well, I mean, a point in the chat that Damian just brought up is this issue is, you know, what is the issue? If you cannot do a physical exam in virtual, you know, it's hard. What can you do? Like, what are the alternatives? Or are there going to be ways in which we can validate approaches and techniques that would be reasonable surrogates for the type of things that would allow us to have meaningful virtual consultations. I presume I'm getting that kind of right, Damian. Please jump in again if it's not quite what you wanted to discuss.
No, that's right, Mo. It seems to me that if we're going to do this sort of thing, we've got to address the question of physical examination. We're all used to take a history, examine the patient, look at the investigations. We don't want to change that model because that's served us well. But how are we going to handle the physical examination? Do we just drop it completely? Or can we come up with some way of providing an alternative? Can we do it virtually? And I've been trying to do that, but I'm really interested to hear other people's ideas about whether they've figured out ways to do that.
I would have thought that the physio group would have been pretty innovative in this area because it's so much of, it's a big chunk of, of your day to day. So I'm curious if anyone here has had experience in what you've been doing.
Well, I think,
go ahead.
Go ahead, Roy. Yeah, I'll comment first. I think when I look at this as well, so I think what we want to be kind of clear on too from a triage perspective is I'm not actually doing my typical biomechanical exam at this point, right? So my job in this situation is one, I think, yeah, you made a brilliant point around setting the expectations with the patient, right? Like this is not me going to go and I'm not going to check all of your reflexes. If we feel that that's important, you will actually be brought into an actual in-person examination with the surgeon if that's what we're actually considering at this point. But my job actually at that point for me is to navigate the system. We know that these individuals do not need to sit on the wait list. So getting them to do very specific, active straight leg raise, really when you think about someone who I need to rule in or out surgical, is there an evidence that's really going to tell me that the passive straight leg raise is that much better? And if there's no caregiver at home, then I'm going to get them to do it actively in a seated position, and I'm going to do a seated slump test as well. So I have the ability to kind of maneuver through there, but really for me, it's just a matter of saying, you know what, in this situation, you don't look surgical. Dr. Senek would then pop in, review the imaging, do something very similar as well for him to sort of feel comfortable to say, you know what, based on what we've seen, we're actually going to move you down sort of the next chain of command for us, which will be kind of our discussion number 2 is who is the right provider? Where do they need to go? Do they require further diagnostics like you talked about earlier, Brad? Do they need some sort of pain intervention? Or actually, do they just need a proper full exam with a physiotherapist or a chiro or whatever it may be? And that is actually where they're going to get into the actual rehabilitative process. Because when I look at really our Canadian system, most people put up this barrier of funding and we haven't even had a conversation with the patient yet. Because even if we all look together, if I was to say to you, you're going to go pay $150 a session that you don't know anything about, very few of us will actually pay $150 for something we don't know. So our job as well is to let them experience and understand what that potential investment may be or how to access funding that they actually may not even know they have. So it's really trying to move them through the system and not get stalled in the process because the process is going to become 4 years is what we're thinking.
So one other thing, if I could just comment on that, one other thing that the group has done as well, which kind of sounds commonsensical, but maybe overlooked, is that with the entire group, we had, trainings of, okay, here's the physical exam components we want to have. Here's some of the ways that we can do this video wise. I agree. You're never going to have, hands-on, but you can really do it in a systematic way, make sure that the entire group is trained to the same thing to collect the same information, and then pick the patients that you need to examine physically in person. I think that's one of the ways we're going to move forward probably.
Yeah, I mean, I was just going to say that the point here is going to be is that whatever technique you use, you've got to have some approach to validating it, right? You've got to have some approach in which you're going to say, okay, we're going to apply as much physical exam as we can for a particular condition. And we're then going to have to do something where we corroborate that and say, were we right when we actually did the inpatient, or some sort of validation check against that? Because until you do that, it's going to be a lot of hearsay, right? It's going to be a lot of, well, we think we do it this way. And it's going to be, it's going to be challenging to convince people that you're actually able to use it in the way you'd like to. So I would imagine there's going to be data there for sure that's going to have to be collected on a meaningful way. And then the question is going to be, what are the other tools we're going to use? But very, very important questions. It's easy to say we should all work together, right? And we should look at movement. We should look at all these different tools. But you have to truly have to find a way to make sure that they are measuring what we think they are measuring. They are both reliable. If multiple people do it, they get the same result, and they're valid, and that they're actually measuring what we think they're supposed to be measuring, right? Those are going to be the two things that we're going to have to sort out. And this is new, really. I mean, while there's been lots of work on it, it's really now an opportunity to do it.
So one of the things that I found, sorry.
Yeah, go ahead. Go ahead.
Yeah, one of the things that I found that actually worked really well for me as a physio was I actually did either a movement screen, or if I knew somebody had a dysfunction, let's say an ACL tear or like a meniscus tear, I'd actually have them perform a video of a simple mechanic like a squat or something like that. And if I know I can't see the video cleanly on screen, I'd have them actually email me the video of doing them independently. And then from there, trying to figure, okay, what is going on? So like Yad said, looking at specific movement mechanics, and can we implement something like that along with the surgical process? Does this actually, does this collapse actually relate to a meniscus issue? And then as Daryl said, like how he was able to do, if you can't do a simple SLR, can you do an active SLR, or can you do a slump test, right? Can you use multiple things like that to help compound what you're seeing, and then from there bringing the team in together?
Yeah, but again, all of that is great. You got to figure out how to validate that, right? Because you're saying I'm doing all this, but you have to figure out, okay, was I right? Like, what were we accurate? Right? And that's the point.
But I think we're all kind of the mindset though that there's going to be one in person for people that may be proceeding to surgery, and for so I see it as a like Daryl said, a triage thing.
Yeah.
And patients are very satisfied with it, but for me personally, if I'm going to operate on them, I'm seeing them, and
Yeah, and and if I go back to this whole issue of value-based, right? The movement is value in the whole chain. There's going to be likely a bundled payment at some point could be given. Say, for the care of this patient, here is the resource you have. Use it wisely, right? And that's going to be the psychologist saying, how do we now as a team, rather than saying, how do we get our piece of the pie in silos? How do we work together to optimize, efficiency of, optimal decision-making for this patient so they have the best outcome? And we do it with a reasonable price tag. And then obviously there's going to be incentives for that. But I would imagine that would be part of that, wouldn't it, Daryl?
Yeah, and I think, this is the big piece that we're going to have to sort of kind of maybe we'll end with as well, because I think everything always in theory sounds good, right? And Mo, I've learned a ton from you as far as, how do we start to validate what we need to do? The problem is it always going to come down to who's going to pay for it. Right. So when I look at, Brad's model, the model that you guys have through, workers' comp actually is great, right? Because it's actually funded, it's paid privately, but yet governed by the government, right? So it's good that way. Surgeons are covered, physios are covered. Damian, will get you to comment too at the end just how the funding would work for you in the UK. But really, when we look at what's sitting in the private sector right now, the question will be is how do we keep the cost to the patient to be zero initially for this triage, right? So if you look at, from a fee code perspective, and I always look at this sort of what are we going to do now versus what may come down the line, right? Because I'm sort of on the mindset that if we prove the model, then we can go and see whether we can get some sort of bundled funding for it in the private clinic. But cost to the patient will need to remain as zero, right? The consultation and the expertise of the surgeon will still be, paid if you think of it just from, the actual consultation fee from OHIP, for example, for us in Ontario. The piece from this is where the physio part will get complicated because the physios say, well, I'm not going to do it for free. Well, the question was, you can't charge the patient yet because they're actually still sitting in a publicly funded system in order to go and see the surgeon. So that part is actually in that consultative model. That part would actually be still covered publicly. So here's how you have to break it down though. And many physios will think I'm an idiot for saying this, but I'm going to call it straight out. The cheapest way to get a new assessment, marketing wise, will still cost you $50 at best. So for me to go in and actually have an employer, like let's say I'm running a clinic and I actually am willing to do this for free, but maybe the clinic will pay me $50 an hour to do it, for example, and I can see 2 patients in an hour, that patient's going to actually have a lot of trust in me, in that ability. And now virtual. So for me, the ability to turn and build a relationship with a patient afterwards and do it for free, one, to learn from a surgeon, to build a relationship with the surgeon, when I look at what I've learned over the years, and not just because Alex is here and, I've learned from him so much, but do you know how much that would cost me to have learned on my own? And it probably wouldn't have been possible. So for me, the return on investment for me to be in that model of care, to give up, 7 hours a week is worth it, because now all of a sudden I've gained a reputation in my community too, that I'm the spine guy for people to go and see. I actually have people that will come back and say, we want you to do my assessment. So I don't do that. This is who I would direct you to go see. That's sort of the triaging model that I would actually assume would need to be had. But for me, the model itself, we have to be so mindful of who's going to pay and how is it going to be done until we can come up with a new solution in a bundled model like we see, with central intake for joints and things like that. So I'll kind of maybe throw it out to the group to see what their thoughts are on that.
And just to put it in perspective for the group, in Ontario, the surgeon bills the Ontario Health Insurance Plan, and the physio is private. And so the patient has to pay for that. The only model in Ontario where the patient doesn't have to pay for anything is this workers network, where it's all included. But right now, the surgeon is a public and the physio is private.
Yeah, thanks, Brad. So, when we think about the impact on the system, though, and if we even just look at back pain, the amount of evidence around fear, anxiety, the need for reassurance, the unnecessary visits to the ED, the amount of individuals that through chronicity and opioid crisis and whatnot, like just the amount of system impact that this could have, if we actually triage people way more upstream, it would have a significant impact and cost savings on the actual system itself overall.
Yeah, but Daryl, I would imagine that can be modeled relatively easily if you look at modeling. So, it would seem to me that making the case for it is not complicated, because it seems so obviously in favor that you would save costs, especially in back pain related issues. But
sure,
it would seem to me that I can't believe that data is not available. Obviously, I'm not aware of all the related information, but if that's not available, it would seem like that's a reasonably good target of energy using these models. So developing these models and then looking at various scenarios and then modeling out costs would be a reasonable first place to start.
If I could step in too. So just to add to, I guess, with the physiotherapist not wanting to work for free and wanting to make some money out of this, just through our model that me and Daryl been using in person and ideally go virtually in the future, a lot of these patients, once again, I'm not saying the ones that I think are 99.9%, surgical based on the MRI, based on the GP sending me like their clinical history and examination. I'm sending people that I think are possibly surgically, possibly not. And so majority of those people need physiotherapy. So they meet someone like Daryl. Well, there's a good chance 50% of the people Daryl's going to see that day, they're going to be coming to his clinic.
Yeah, that's true too.
Sure.
Folks, I do want to be very respectful of your time and very respectful of your early morning, Damian. But we are at an hour. These discussions can go on for hours and hours. But I do think it might be helpful at this point to bring it to a close and maybe have another plan that we'll reconvene in a little while with another episode of this, and we'll probably get some other perspectives as well. So hopefully we'll make sure you all join us for that one as well. Let me first by thanking all of you for coming and participating actively. I hope you find this to be a little bit more helpful than maybe some of the other approaches that we could have tried. Let me also thank our speakers, both Alexa and Daryl, for taking time and energy to do this, and obviously Brad for helping co-moderate this. And if I could, I will leave the last words to our speakers, Daryl and Alexa, before we close out.
Yeah, I'll close by just, I want to just thank everybody for the opportunity to come and speak. And for me, sometimes posing an idea is great because it just gives us a chance to break it down. And during these times of chaos comes so much opportunity. But as Mo says, it's the collaborative efforts of all of us that will actually start to move the system forward. So just a huge thanks to you, Mo, and your team that actually put this on. And I really appreciate the invite. So thank you guys.
Great. Alexa?
And I just want to thank Mo, firstly, and the rest of your team for putting this together, and also Daryl for inviting me to come on to be his speaker with him. It's been a great experience working with Daryl. I think we have a great collaboration as a physiotherapist and as a surgeon. I really enjoy working with him. He's fantastic.
Superb. I think we have a lot to look forward to, and I hope all of you kind of get charged up a bit to continue to look at this area a bit, as critically as we can, because you need champions who actually want to work together in a way and develop these models. So we'll continue to push this, and I think it's a really great topic.
100%.
Great. Everyone have a great evening.
Everybody.
And have a great morning, Damian.